Good evening, everybody. I just wanted to cover a little bit of what I've learned about the COVID-19 virus, or the Corona SARS-2 virus, in the last week and a half. And I've learned a few things. First, I'd like to just briefly cover the issue of infectivity with regards to the coronavirus. Infectivity of viruses is basically given a value called an R value. It's R0 or R0. And that is a gauge of the infectivity of a virus. At the top of the scale, we have measles, which apparently has a R0 of somewhere close to 15. And we have influenza, which is, or regular flu, which is somewhere around an R0 value of about 1.8. And originally, the early studies coming out of China appeared to indicate that the COVID virus would have an R value of maybe 2.2, maybe 2.5. And this sort of depends on what kind of studies you select. The Center for Evidence-Based Medicine has a great paper, which I'll put in my description, a link to it in my description, to get that goes ahead and discusses the R0 value as well as the effective rate of transmission, which as more and more people get infected, you get a reduced rate of transmission of a disease because more and more people are immune, so there are more and more dead ends associated with it. The Emerging Infectious Disease article, that is a pre-published article from the CDC, covers the COVID-19 and is more of a coalescence of multiple papers in a more comprehensive fashion. And given the later information that has come out of not only China but Europe, South Korea, etc., the R0 value or R0 value of the COVID-19 virus is about 5.8, which places it just below smallpox and places it at one of the most infectious diseases virus-wise that has been out there. And what that means is that under ideal circumstances, somebody with the flu could potentially pass it on during the course of the infection to roughly 9 or 10 people. With the COVID-19 infection, given its longer viral shedding period during incubation as well as symptoms and recovery period, under ideal circumstances, you could potentially infect as many as 1,200 people. Now, that's an extreme in both cases. It obviously depends on the number of people you come in contact with, how close you come in contact with. But under ideal circumstances, you can look at this virus being 3 to 4 times more infectious than the flu. And if you were, for example, a subway rider on a routine basis, and you were infected, didn't know you were infected, or you're one of the asymptomatic/pre-symptomatic people, you could get on a subway train and be close to 4, 5, 6 people each time you got on a subway train. If you switched cars 2 or 3 times, that'd be new people to expose each car. And if you managed to cough into your hand and rub it on a support rail or handrail on the subway, as well as standing in on the platform, you could imagine that you could probably infect 30 or 40 people during the course of a day. And so during the course of 20 days worth of infection, you could infect probably a lot of people. But again, those are under ideal circumstances. And so the biggest thing to do is to reduce the risk of infection, which is obviously why we've had all the social distancing. I'm also going to reference a paper in there that covers social distancing and other practices that we've enacted for the COVID that have multiple studies supporting them for influenza virus, in other words, the flu. And simple things like social distancing essentially reduces transmission of the flu by 23 to 27%, depending on which particular paper you read. If you close down a school prior to infections getting out, you reduce the infection rate by about 40%. A combination of hand washing and wearing a face covering reduces it by between 11% and 27%, depending on what particular study you apparently look at. Travel bans, whether or not they be train or plane, are usually taken in conjunction with other things, so they do appear to result in certainly a reduction of infection, but the study was less certain on that because there were often other actions taken to mitigate the disease process as opposed to just travel ban. But obviously, if you reduce the number of incoming infectious individuals, you obviously reduce the amount of infection that gets spread throughout the community. The more infectious an agent is, obviously, the more impact that probably has. So in this particular case, travel bans were undoubtedly a good idea. I've noticed that on multiple news shows and whatnot, people are talking about, well, this has been in our system for a long period of time, and there are multiple people that, have been infected with it, and that's the reason why California has not had as much disease process and rapid spread as New York has. And I don't know if any of that is true. I try to be honest with myself and anybody else who happens to be watching the video. I have no clue as or not that is true, but when I look at the difference in mass transit between areas in California and areas in New York, you have to wonder whether or not the subways played a big role in transmission and infection of the disease. They're not identical areas, so it makes it very difficult to go ahead and make an identical comparison and say, well, they only had this many disease and you had this much disease, so everybody must have been infected in California. And again, I don't know if that's true. They've had some recent studies on some antibody testing coming out of California Bay Area showing a significant amount of people testing positive for antibodies. But there is a dependence upon what kind of antibodies they're testing for, because it has to be specific for this particular coronavirus. As I stated previously, the laboratory at the Wuhan Virology Institute, or Institute of Virus, has 1,500 separate coronavirus cases. So obviously there's going to be some overlap in coronavirus reactivity and antibodies. And the question is whether or not an earlier coronavirus was present in California, which imparted some degree of immunity, as opposed to this particular coronavirus. Because certainly if this was widespread in California, you would have been seeing substantial issues with hospitalizations, ventilators, and a more urgent sense of panic if you had this particular virus running rampant in California at the time. At least my common sense tells me that that's what would have happened. There have been cases in the Spanish flu, for example, where there was a younger population aged 25 to 40 that was affected tremendously by the Spanish flu out of proportion to normal viral infections and lesser impact on the older populace. And there was a hypothesis that a previous, less viral version of that virus had been in the community, and the older people, 20 years earlier had been exposed to it, and so there was less death than expected for the older population group as a result. Similar to the earlier virus that was present in the I believe it was the early part of this decade, in comparison with people likely of having had an exposure to it in the 68 or 70s to a virus of similar type, which resulted in some partial immunity developing. So certainly partial immunity from a prior virus is a possibility, and that may have imparted some protection for a certain subset of the population. But I think that if you just look at hospital admissions and ventilator use and ICU use, you wouldn't go ahead and say, oh yeah, this virus of this particular virulence was present throughout California at the time, far earlier than people suspected it was going to be there. But again, that's just common sense mechanism in my brain speaking out. I have no facts to back that up, other than the facts that there have been prior disease processes that theoretically have introduced partial immunity to the population. In any event, because of the infective nature of the COVID virus, you need to reach a certain level of immunity with regards to the population in order to make it unlikely for further transmission to be possible. And given the infectivity R0 value of the COVID virus, it is likely that you need 80% of the population to be immune to it in order to substantially reduce any further infections. In other words, an infection rate of essentially 0, or an effective transmission rate of 0, which is an RE or RT value. Anyway, if you're more interested, you can certainly look at the papers that I included. I will also cite several papers that have discussed potential prophylaxis in viral therapies, as well as early results of less than optimally designed studies out of China and some other locales that have indicated that there is a decrease in CT infiltrates of the lungs on patients on the hydroxychloroquine and zithromycin therapy, as well as decreased in the recovery of viable virus from nasal swabs versus control groups treated with traditional therapies. So there is a possibility that the hydroxychloroquine does help, but again, we're doing substantial controlled trials currently underway of probably a couple of thousand patients, and so we'll know better. And there are several trials going on as a potential prophylaxis treatment regime as well, and hopefully that will also come to fruition in about 3 weeks with some early results. There have been several studies that are just finishing up with regards to antiviral therapy. They had several antiviral therapies performed in China with conventional Chinese medicine treatments. So you don't get a pure, this one treatment did this. There's a muddying of the waters with the combination of the Chinese traditional therapy and Western antiviral therapies. There are some that show improvement with some of the antivirals, and there are some that don't show improvement, but we don't know what impact the Chinese medicine component had on those, and we don't know how well the studies are run, because even the Chinese researchers that wrote the review article were not particularly complimentary of how the studies were actually run. So you have to look at it from the standpoint of it's less than optimal scientific method being used in order to adequately assess the results. But again, we do have antiviral therapy that's being completed, I believe, in Detroit with the Gilead Sciences remdesivir, as well as multiple hydroxychloroquine azithromycin studies. And again, we've got some antiviral studies given prophylactically to medical workers, etc. So it looks like about 3 weeks from now we'll have a truly significant amount of results from these research studies in order to come up with some potential conclusions going forward. Obviously, it'd be great if we could go ahead and come up with a relatively safe prophylactic treatment that doesn't necessarily keep you from getting the virus, but may go ahead and substantially reduce symptoms and certainly reduce complications. And then you could let the virus kind of run wild and not worry about it at all, and not worry about the potential second or third waves that are likely to come about. Let's see. For those of you who stuck it out this long, I came across a website that's located in Houston. It's called Zuma Office Supply, ZUMA. And they do have actually toilet paper and paper towels in stock. And it usually arrives within 2 days. So if you wanted to go ahead or had need of toilet paper and paper towels, you could certainly give them a try. And I guess that's about it. I will go ahead and post another video probably tomorrow on the Wuhan lab and the contamination that's likely to have come from the Wuhan lab, now that we know that patient 0 was actually a tech at the lab via various government sources. Anyway, I'll cover that tomorrow. Have a good evening.